Your arteries may be building danger right now, quietly, without pain, and the moment when that hidden trouble becomes a crisis is often the first time people notice. Hi, I'm Dr. Artur Brasil. If you're a man over 60 or you care for someone who is, this is one of the most practical conversations you can have about everyday prevention. Today I want to show you, in clear medical terms, how a low-dose aspirin strategy, used correctly and under medical supervision, can change the immediate risk picture around a vulnerable plaque. The headline on this video is dramatic. How to use aspirin to clean your arteries, the method your doctor never explained. Let me be blunt. Aspirin does not physically scrape plaque out of your arteries. But used in the way I'll describe, it can reduce the chance that a plaque will trigger a life-threatening clot. That distinction matters, and I'll keep coming back to it. Before I go further, a quick request. If you want more practical guidance aimed at men over 60, subscribe and tell me in the comments if you or a family member have heart disease or are concerned about stroke. That helps me tailor what I bring next. Atherosclerosis, the slow narrowing inside your arteries, begins in silence. Years of risk factors, high LDL, high blood pressure, smoking, diabetes, metabolic stress, injure the inner lining of the artery, the endothelium. When the lining is damaged, cholesterol particles sneak into the wall, inflammatory cells arrive, and over time, a plaque grows. That plaque can make the flow narrower, but the immediate danger usually comes not from the narrowing itself, but from a sudden event. The plaque surface tears or ruptures. When that happens, the body senses injury and sends platelets to plug the damage. Platelets are tiny cells designed to stop bleeding. They clump together quickly. When they do this inside a coronary artery or a cerebral artery, they form a clot that can block blood flow and cause a heart attack or stroke. So where does aspirin fit in? Aspirin's power in cardiovascular prevention comes from what it does to platelets. At low doses, aspirin irreversibly blocks an enzyme called cyclooxygenase, COX, inside platelets. That prevents platelets from making a molecule called thromboxane A2, which is a powerful signal that tells platelets to aggregate. Since platelets have no nucleus, they cannot replace the blocked enzyme. The antiplatelet effect lasts for the lifespan of the platelet, roughly 7 to 10 days. Practically, that means that if a plaque ruptures, platelets are less able to form a dangerous clot quickly. Aspirin also has modest anti-inflammatory effects on the arterial wall, which may help slow processes that make plaques more unstable. Together, these actions reduce the chance that a rupture will result in a complete arterial blockage, not by removing the plaque, but by lowering the probability that a ruptured plaque will cause a thrombotic catastrophe. That's the medicine. Now, the practical, safe approach I want to be clear about. There are 4 core elements to how low-dose aspirin is commonly used for cardiovascular protection: dose, formulation, timing, and the context of other medications and conditions. I'll walk through each and explain why they matter. First, dose. For cardiovascular prevention, the low dose typically used is in the range of 75 to 100 milligrams per day. This is very different from the high analgesic doses, 500 to 1,000 milligrams, people use for pain. Those higher doses do not offer additional antiplatelet benefit and substantially increase the risk of gastrointestinal irritation and bleeding. The low-dose range provides enough aspirin to block platelet COX effectively, while minimizing systemic side effects compared with repeated high-dose use. If you see enteric-coated tablets of 81 or 100 milligrams, those are the kinds of formulations people use for daily cardiovascular protection. That said, all aspirin increases bleeding risk to some degree. Low dose reduces that risk compared with high doses, but it does not eliminate it. Second, formulation. You may have heard that enteric-coated aspirin protects the stomach. Enteric-coated tablets are designed to pass through the stomach and dissolve in the small intestine, which can reduce local gastric irritation for some people. However, enteric coating is not a guarantee against stomach bleeding or ulcers. If you have a history of peptic ulcer disease, gastritis, or are taking medications that increase bleeding risk, enteric coating does not make aspirin risk-free. The decision on formulation should be discussed with your physician, considering your gastrointestinal history and other medications. Third, timing. Our bodies are not constant hour to hour. The risk of plaque rupture and thrombosis follows a circadian rhythm. Many cardiovascular events, heart attacks and ischemic strokes, tend to occur more frequently in the early morning hours. Blood pressure surges on waking, and platelets are more active then. Evidence suggests that taking low-dose aspirin in the evening or at night can align its peak antiplatelet effect with the vulnerable morning period the following day. For that reason, clinicians and some studies suggest taking aspirin at night, roughly in the window of about 9 to 10 p.m., so the maximal platelet inhibition coincides with when platelets are most likely to cause trouble. I need to be cautious. That phrasing is evidence-framed, not absolute. Different patients have different routines and co-medications. Timing should be individualized in consultation with your doctor. But understanding the rationale, align antiplatelet effect with morning risk, helps many people use aspirin in a way that makes physiological sense. Fourth, context and dangerous interactions. Aspirin's benefit and risk profile depends critically on what else is in the bloodstream. There are 4 mistakes I see commonly and that you must avoid. Taking aspirin together with certain non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen or naproxen, in a way that blocks aspirin's effect. Adding aspirin to an anticoagulant such as warfarin or a direct oral anticoagulant without medical oversight. Taking aspirin when there is an active peptic ulcer or a recent history of significant gastrointestinal bleeding, and abruptly stopping long-term aspirin, which can cause a temporary rebound in platelet activity and possibly increase short-term risk. Each of these scenarios requires a doctor's input. Let me explain the NSAID interaction in simple terms. Some NSAIDs, when taken before aspirin, can occupy the same platelet enzyme site and prevent aspirin from irreversibly binding. That means a familiar painkiller like ibuprofen can reduce or block the protective effect you're trying to get from aspirin if the timing is unfavorable. For patients who need both medications for different reasons, clinicians often advise a specific timing strategy or alternative pain control. This is not something to improvise. Discuss the plan with your physician or pharmacist so that your aspirin retains its protective function. When it comes to anticoagulants, warfarin or the newer direct oral anticoagulants, DOACs, combining them with aspirin raises bleeding risk substantially. There are specific clinical scenarios where combination therapy is indicated and others where it is not. That decision must be individualized and managed by a clinician who understands the trade-offs. If you are on any anticoagulant, do not add aspirin on your own. Active peptic ulcer disease is a relative or absolute contraindication to starting aspirin as a daily preventive agent until the ulcer is addressed and the bleeding risk assessed. If you have a history of peptic ulcer, prior gastrointestinal bleeding, or are taking other drugs that irritate the stomach, that changes the risk calculation and requires careful discussion. Finally, abrupt discontinuation of aspirin after long-term use can temporarily increase platelet reactivity. This is one reason why stopping aspirin without a doctor's guidance is potentially dangerous. If you and your physician agree that aspirin should be stopped, they will advise the safest way to do so, given your history. Now let's be practical. What might a safe protocol look like for someone who is already a candidate for aspirin under their doctor's guidance? Remember, this is an example of a commonly used approach. The exact plan for you should be determined by your clinician. One commonly used regimen for eligible patients is a daily low dose of aspirin in the 75-100 ml range, taken in an enteric-coated formulation if GI sensitivity is a concern, and taken in the evening to align protection with early morning risk. Many patients swallow the tablet with a small bite of food, a piece of bread, a spoonful of yogurt or a few crackers. To reduce the chance of gastric irritation, taking it with a sip of water is important. Again, if you have a history of ulcers, bleeding, or are on other blood-thinning medications, discuss alternatives with your physician. The exact pill, the exact timing, and whether you should take it at all are individualized decisions. Aspirin is not a standalone solution. Lifestyle choices complement and sometimes enhance the protective environment around your arteries. Certain dietary measures have supportive evidence for vascular health and may synergize with the goals of antiplatelet therapy. Extra virgin olive oil as a primary fat, regular servings of berries rich in anthocyanins, raw garlic in moderate culinary amounts, cold water fatty fish such as salmon or mackerel for omega-3 fats, and green tea. These foods have anti-inflammatory and antioxidant properties that can reduce vascular inflammation and improve metabolic profiles. For practical planning, use olive oil instead of butter when you can. Aim for a couple servings a week of fatty fish. Include a handful of berries several times a week. Add garlic to meals if it agrees with your stomach, and consider a cup of green tea as a regular habit. None of these foods replace prescribed therapies, but together with appropriate medications, they create a healthier vascular environment. Let me tell you about So Antonio, a patient who helps illustrate how knowledge plus supervision can calm fear and improve outcomes. So Antonio is 67 and lived with a constant anxiety about his heart after learning that a cousin had a heart attack at 62. He'd been taking occasional over-the-counter aspirin for headaches, but he didn't understand the difference between that and a daily low-dose strategy. In our consultation, we reviewed his cardiac history, medications, and gastrointestinal risk. He had established coronary disease on his prior tests, a clear indication where low-dose aspirin is often part of secondary prevention, and no recent GI bleeding. After a careful discussion and agreement with his cardiologist, he started a daily low-dose aspirin, taken at night with a small snack, alongside the statin and blood pressure medicines he already used. At follow-up, he reported sleeping better because his anxiety had settled. His inflammatory blood marker decreased, and he felt more confident. That improvement is his story, not a guarantee for everyone, but it highlights how a guided approach reduces fear and focuses on meaningful risk reduction. We must also be honest about who should and should not take aspirin. For people who already have known cardiovascular disease, prior heart attack, stent, bypass surgery, or ischemic stroke, low-dose aspirin is a cornerstone of secondary prevention in many cases and has a strong evidence base. For primary prevention, that is, people without established cardiovascular disease, the picture is more nuanced. Low-dose aspirin may be beneficial in selected individuals at higher risk of cardiovascular events and low bleeding risk. But for many low-risk individuals, the bleeding harms outweigh the benefits. Guidelines from major organizations have evolved toward more selective use of aspirin in primary prevention, so the decision must be individualized and discussed with your clinician. If you fall into a gray zone, for example, you are older than 60 with diabetes and other risk factors, that calls for shared decision-making with your physician. There are a few common scenarios I want you to recognize as red flags where you must talk to your doctor before touching aspirin. If you are taking any anticoagulant for atrial fibrillation, artificial valves, deep vein thrombosis, if you take frequent NSAIDs for pain, if you have a history of peptic ulcer disease or gastrointestinal bleeding, if you have a bleeding disorder, or if you are slated for surgery in the near future. In these situations, the trade-offs are complex and require professional management. You might be wondering about the idea of stopping aspirin if you already take it. Don't stop it on your own. If you and your physician determine that the risks now outweigh the benefits, your doctor will advise the best plan to discontinue safely if needed, and will consider alternatives. Let's summarize into a practical checklist you can bring to your next visit with your doctor. This is what I want you to write down or show on your phone. Bring to your appointment a list of current medications, including over-the-counter NSAIDs and supplements, a history of any gastrointestinal bleeding or ulcers, any history of bleeding disorders, your history of cardiovascular disease, past heart attack, stroke, stents, bypass, and any other major conditions like liver disease or chronic kidney disease. Ask your doctor, am I a candidate for low-dose aspirin for cardiovascular protection? If I am a candidate, what dose and formulation do you recommend? Is nighttime dosing appropriate for me? How should I manage pain if I also need an NSAID? Do I have any gastrointestinal risks that change the plan? If I am already taking blood thinners, is adding aspirin recommended? If I stop aspirin in the future, how should we do that safely? A few practical pitfalls I want to restate because I see them often and they can be dangerous. First, don't treat occasional headaches or pain with a daily low-dose aspirin regimen. Those are different indications. Second, avoid taking ibuprofen or naproxen in a way that cancels the effect of your aspirin. Coordinate timing and choices with a clinician. Third, don't add aspirin to an anticoagulant without medical supervision. Fourth, don't assume that enteric-coated means zero GI risk. That's not true. Finally, don't stop aspirin abruptly without medical direction. If you're still thinking, my doctor never talked to me about this, I understand that frustration. Medicine is complex, and brief office visits make it hard for clinicians to cover every detail. That's why I encourage you to use this information as the basis for specific, respectful questions at your next appointment. It's not a substitute for a clinical conversation, it's a way to make that conversation more useful. Ask whether you're in a secondary prevention group where the evidence is stronger, whether your bleeding risk makes aspirin inadvisable, and what the best timing and formulation would be for you personally. Before I close, let's return to the core truths I want you to take away. Aspirin at a low daily dose reduces platelet aggregation and can lower the likelihood that a ruptured plaque produces a dangerous clot. It does not extract or dissolve plaque. It's a risk-modifying tool, not a cure. The best use of aspirin is individualized. The benefit is strong for many people with existing cardiovascular disease and selected high-risk individuals, but it carries bleeding risks that must be weighed. Timing the dose at night can make physiological sense because it aligns protection with the morning rise in clotting activity. Enteric coating may reduce stomach irritation for some, but does not make aspirin harmless. Never combine aspirin with anticoagulants or start or stop aspirin without medical guidance, and be careful about NSAID interactions. If this message resonated with you, share it with someone you care about, a sibling, a neighbor, a father, or a friend who may be at risk. Bring the checklist and the questions we talked about to your next doctor's visit. If you haven't yet, subscribe for more evidence-framed guidance focused on practical steps older adults can take to protect their hearts and lives. Thank you for spending this time with me. Take these questions to your clinician, be proactive, and remember, the goal is not to chase dramatic fixes, but to reduce risk with safe, evidence-based strategies under medical supervision.